Okay, you can get started whenever you're ready, Elvie.
All right. Good evening, everyone. Welcome to the January 13, 2022 meeting of the Community Board 6 Health and Human Services Committee. My name is Elvie Barroso, and I'm the chair of the committee. This meeting is called to order at 6:34. Tonight, we are joined by Assistant District Manager Brendan Burt. Members of the public, you can raise any questions or comments that you have through the Q&A feature of Zoom. If there is time following the committee's discussion, we will field questions from the public. Raj Najjar has volunteered to take minutes tonight. Thank you so much, Raj. You all should have received an email from the board office with a link to a doodle sign-up sheet for minutes takers at your committee meetings in 2022. For your convenience, the link to the sign sheet is being posted in the chat room now. We will now take attendance by roll call. Brendan will conduct the roll call.
Committee members, I will call your name and you will unmute yourselves. When your name is called, please say present. I will announce if there is quorum. Okay. Marty Barrett.
Present.
Elvie Barroso.
Present.
Dan Devine. I do not see Dan here. Sandra Leftoff.
Can't unmute, hold it. Here. Did I unmute?
I heard you. I heard you. Your count is
Okay,
here.
it didn't show up on my screen. Okay, got it.
Rich Mintz.
Present.
Raj Nayar.
Present.
Anju Suresh.
Present.
Ronnie White.
Present.
We have a quorum.
Good. The agenda for tonight's meeting was distributed ahead of time by the board office and is reflected on the screen before you. If there is no objection, we will adopt the agenda. Members of the committee, if you object to adopting the agenda, you may raise your hand through Zoom. Seeing no objections, the agenda for tonight's meeting is adopted. The minutes from the December 9th meeting was distributed ahead of time by the board office. If there is no objection, we will adopt the minutes as drafted. Members of the committee, if you object to adopting the minutes, you may raise your hand through Zoom. Seeing no objections, the minutes from the December 9th meeting are adopted. They will soon be available on the CB6 website. In order to conduct an efficient meeting, let's observe a few ground rules. No one may speak until granted the floor. Committee members, if you have a question about committee business or wish to make a motion, please raise your hand through Zoom. The chat function should not be used for committee business or questions about agenda topics. All such remarks should be made on the record by raising your hand through Zoom. Chat should only be used to alert us to any technical difficulties you are having or to state in writing information that was already stated aloud on the record during the meeting. When a committee member is given the floor to speak, I will identify you, and you can unmute yourself so that you can speak. We are required by New York state law to create a verbatim transcript of the meeting. So please keep your questions and comments succinct and germane to the discussion. The order of the adopted agenda should be followed. In tonight's agenda, we will continue to discuss on the legislation that would establish a single-payer health insurance system for New York State residents. Andrew will give us an update about this legislation. Andrew?
Yes, thank you, Elvie, and good to see everyone again coming out of the new year. So we had in our last meeting representatives from the New York Health Act come and speak to us about legislation that's going to get reintroduced. I think at this point, at least the 5th or 6th, if not more times, this upcoming spring. So they ran through what the legislation entails, a chance to ask questions. I believe what we had discussed coming out of that is really pausing on any action until we see that the legislation gets reintroduced in the state and the Assembly and the Senate. I'm not sure what the current status of that is, so I can check in with one of the presenters, Naomi Zawade and Yuling, to see what the current status is. But that is the expectation that it gets reintroduced. If we're interested in, as a board, doing anything in response to that, I know it's a little bit on a larger level than the more hyper-local issues that we focus on, but wanted to put that out there as well. So I don't know if anyone had any thoughts coming out of that last meeting. I know it's been a while. Or any ideas on next steps. Otherwise, I can plug back in back with Naomi and Yuling to see if what the status is of the legislation and when it's getting reintroduced, as well as any opportunities for us to engage if we're interested.
So as community board committee, what can we do to support this legislation?
So I'm thinking one idea might have been just a resolution. I'm open to it. This is I think the floor is open for ideas. I know, Ronnie, I see your hands up. If you want to.
I'm sorry, hi. Can you just give us a brief overview again, please? Thank you.
Yeah, so the New York Health Act would essentially establish a single payer system in New York State. And so it would effectively abolish private insurers and ensure that that those who are currently uninsured or underinsured have access to high quality, affordable care. And so during our discussion back in December, we had spoken about we've spoken about a lot of things. One being just the merits of a single payer system versus a public option, and really some of the economics behind why it is a long-term, more economical option. It's the minutes, I think, also do a good job of kind of capturing some of those details as well. And they had a presentation that we can also distribute, but that's the long and short of it is it's the New York Health Act is to help establish a single payer system in New York State and be at the forefront of other progressive states in doing so.
Thank you.
So we don't necessarily have to do anything with this. I mean, I thought it was a great discussion or interesting discussion and a good like educational session, if nothing else. But I did want to put it out there if we wanted to move forward and show our support. If we have support for it, then I just wanted to open the floor to it. Or if anyone had feedback from that meeting.
Marty, what do you think we can do? Marty, please unmute. Unmute yourself.
Has his hand raised.
Did you just call on me?
No, I called on Marty, but I
Okay.
think Marty, please unmute.
Yeah, we can't hear you.
No, we can't hear you. All right, while waiting for Marty, I think Rich.
I would just want to say that I would love to have us endorse this, even if it's just symbolic, because obviously, to have an impact, there has to be a much larger coalition than us, because it's state legislation that will have a lot of opposition and has a lot of wide impacts. But I don't, it wouldn't bother me to be out there.
So you suggest that we should write a resolution.
I would support that.
Okay.
I see Raj has his hand raised.
Okay, Raj. I can't see it.
To piggyback off of what Rich said, I agree. I think that for us to do a resolution in support, not only are we like reintroducing it as a community board, but if we are successful in passing it with our board, it would go to a borough board. So potentially it could be picked up by other community board, in Manhattan, and having that, unified support, I think would, definitely get a lot of eyes and attentions of our elected officials to, do something with this bill. So I too am in support of drafting a resolution.
Okay, so I think Sandra.
Yeah, I just felt I came out of that with a lot of questions that were not answered. And so I, for one, would like to know something about how the medical world is going to be incorporated, what the issues are for them, what that means, in terms of the functioning of our medical system. So I felt I didn't feel I heard it. And I would be very hesitant to draw up a resolution without understanding the economics of it, how it impacts on the functioning of the medical world. And I had the feeling I didn't feel like I learned much about that. So it seems premature for me. You folks may know more than I do.
Marty, hopefully. Yeah.
Hopefully now, yes?
Yeah, good.
Hey, son of a gun. I had questions as well. There are many people and unions that like the way their insurance currently covers their health plans, and to have a singular insurer rather than the way they've been doing it, there would have to be a great a great incentive insofar as reduced cost, and that would have to be proven all along. I didn't really hear a discussion towards that within the presentation that we had. It may have been, but I didn't catch it.
Yeah, me too. I'm not sure about the quality of care that we can get when it comes to getting a single payer health insurance. So I really, me too. I want to know more about that. Yeah. So, anybody else from the members of the committee?
I see both Ronnie and Dan have their hands raised.
Okay, Dan? I can't see Dan. Dan?
Yes, yeah, I think that this frankly is just way too big of a topic for us to be addressing at our level. And what I mean by that is, having been on the community board for about 10 years now, what I've recognized is that our strength is our ability to be able to take things that are hyper local and be able to kind of affect from the ground up. And I just feel like I don't feel comfortable given all of these massive questions around quality of care, who's insured, what that would cost, et cetera, where we're necessarily in the position to commit to a resolution that's going to be as most effective as possible. It doesn't necessarily mean that this isn't something that we shouldn't be looking at, or, you know, that it is not a public good that should be considered. But just from again, on the time on the community board, I feel like the things that we've been most effective at have really started from kind of the street corner, basically up. And I remember from our meeting last night, one of the things that was mentioned was that council member or state senator Epstein is actually retiring. Whether or not I heard this correctly, I certainly stand to be corrected, but I believe he served 52 years in public service. And he, in fact, is the main person who's the sponsor of this bill. And as I understand as well, he's been putting this before the floor since 1992. So I just really question, is this the most effective use of our time in terms of affecting positive change for the community and residents? And based on what I've seen thus far, I don't think it is.
Very good point, Dan. Brandon, do you see any other hands? Because
Yeah, I see three hands raised. I see Ronnie's hand is raised, Marty's hand is raised, and Rich's hand is raised. I think Ronnie had their hand up first.
Okay.
Hi,
Ronnie?
thank you. Yes, I just have to agree with you, LV, and the last few committee members. We have to be a little bit more granular and flesh out the details. Thank you.
Good. Marty?
This community board over the years has done some really spectacular things. For instance, and this is the feather in my cap that I am most proud of as far as the community, my almost 30 years on the board. In almost every school, playground, workout facility, commercial building, you see automatic defibrillators. That came from our committee, well, from the Public Safety Committee at the time. Having seen a pilot program that was occurred in Seattle, I brought that information to our committee, and we passed a resolution to have automatic defibrillators in CB6 and in the emergency vehicles, police, EMS, and fire engines. And it became throughout the city, throughout the state. Granted, Senator Goodman put $10 million behind it since he thought it was a good idea as well. But this is something that came from CB6. And so it isn't impossible if this is something that we find that would be most helpful to the folks in CB6. And there are, I'm sure, well, we could find the numbers, how many uninsured people there are here, to bring it forward. So long as we know the details, though. That's the questions that we've been raising certainly are valid and may be enough to kill it or not. I've used the National Health Service in Canada a couple of times, and in England, and it was fairly quick, and of course, you didn't have to pay anything.
Any other hand? Was it Min? Rick?
Yes, I just want to acknowledge that Dan made a good point. That I personally support this, but I do think that before we take any action, we should look into more of the mechanics of how it would play out. Just because, if for no other reason than that, I don't think it'll pass full board without having a clear understanding of what the transition plan would be and how people who are currently happy with their insurance would survive that transition. I'm less concerned with what the industry says because they'll oppose any change, but I do want to make sure that individuals are covered in some way so that it's not too disruptive.
Sandra?
Yeah, I also want to play with something that Dan said. I'm also functioning on the hyperlocal level, but what I would really appreciate is us making a list of what we think the kinds of issues are we want to deal with over the year, so that we're making a series of choices about our hierarchy and what are we feel, each of us feels are pressing issues. I know when I joined the committee, I had certain things in mind about the issues in the community that in terms of health and that I was concerned about and hope would be addressed. But it would be, I find very useful if we could construct a list like that, that each of us would, have some input on what they would like to see addressed, and then we can go from there. So that would be my recommendation.
Andrew?
Yeah, actually, I want to second both what Sandra and Rich have just said. I really do like the idea of having a running list of topics that we as committee members care about as a reason that we're in a Health and Human Services Committee and want to bring to the floor. So I do 100% agree. This is one of the topics that I cared about, which is how it ended up coming up as a topic for discussion for us. And I'd be interested in hearing other topics that people have in mind. I don't disagree with what anyone has said. I mean, I am not an expert on this. It's very deep. The people who spoke to us last time, they straight up have PhDs who are able to speak and answer that level of detail and go into the mechanics. Their presentation was focused more on the economics of having a system like this. And then as well, of course, it's hard to dissociate from that, or separate from that, the importance of it, given that we're still very much in the brunt of a pandemic where people aren't able to have access to the care they need, which is another reason why there's been so much focus and new energy being given to the New York Health Act as of recent, just with widening disparities and the fact that people are still being heavily affected by COVID. So agree with what everyone said. I would move to, from what it sounds like, I'll reach out to the speakers that came and presented to us last time. I'll make sure to get the presentation from them because I don't know if we've gotten that yet, and it does list out some data and some charts that I think would be interesting for us to reference. I'm still trying to get my head back around to all the committee meeting business since coming back from the holidays itself, so I need to go back and review that too. So I'll go back and I'll request the presentation, and I'll also just see if they can give us a status update on where the New York Health Act is and any other events that they might be having. And I think from there we can potentially circle back on this topic. I know I've listed out some of the questions. I've noticed some of the questions that committee members have expressed here. If there's any other questions you may have, you can go ahead and chat me, and I will include that in my email over to them as well.
Yeah,
that's
I think
good
that's
next steps.
Yeah, that's good, Andrew. So you can make a list and you can send it to them, and they can come back again. So do you think they can come back in February, or we should push in March?
I'll send the responses that I get for those questions, and I think we can decide from there if we're okay having an email conversation ahead of bringing them back for another meeting, or if there's any other topics that people on the committee would be interested in discussing. So I'll pass along to the rest of the board the response that I get back from them on those questions and potential ways of, or yeah, current status basically, and we can kind of go from there, I think.
Yeah. Okay, good.
Sorry to interrupt, but one thing I'll interject on here is with regards to finding the presentation for from last month's meeting. So you can actually find the presentation on our minutes database. I can post a link to it in the chat. Link to the presentation from the minutes database as well as the minutes database itself. But yeah, I just wanted to point that out for anyone who wants to look at the presentation itself from last month.
That's good, Brenda. Okay, so now we're gonna move on to the second topic. It's about discussion on the retired municipal employees that was moved to the Medicare Advantage Plus plan. Our speaker for tonight is Bonnie Nelson from John Jay College, retiree, and is the PSC Executive Committee Retiree Division, who is very active in the healthcare of retirees. So, Sandra, you wanna add more to the introduction on Bonnie?
Sure, I'd be delighted to. Let's see, first of all, I've known Bonnie for many years from the college, but particularly I've gotten to know Bonnie much better over the last 6 to 8 months as we have gone through this terrible upheaval in our medical coverage as retirees in the part of the municipal labor organization. And Bonnie has been a godsend to all of us in terms of the depth of her knowledge about what is happening, both to our to the healthcare debate, what happened behind closed doors, and what's happening now as we attempt to resist what is being thrust on us by the Office of Labor Relations. So I'm really very excited to hear her presentation and learn from it. So welcome to our little committee. And thank you so much for doing this. We're all very grateful to you for doing it and being here with us.
Thanks very much. I've been at many Zoom meetings. This is the first time that I'm actually doing a presentation at one and sharing screen. So please let me know if things don't work well. And I'm going to share my screen now. Did that work? Is that working? Can you see it?
No.
I don't see anything yet.
No. No.
Okay.
You'll need to press the share screen button.
I
And then
did
select.
that, and I'm trying to select the right.
You'll need to select on the there
Did
we
that
go.
work? Okay.
Yep, that worked.
All right. Okay. So, okay, so like Sandra left off, I'm a retiree from John Jay College, CUNY. One of the retirees that New York City is trying to move from traditional Medicare to a Medicare Advantage plan. What I want to do this evening is provide some history and context and explain why this move should alarm all of us. And I want to point out first that Medicare is a single payer system. It started as a single payer system, and we are gradually moving away from that. And this move that the city is trying to do is an example of that. So first, why is New York City trying to make this move and force all its retirees from what they like in traditional Medicare to a Medicare Advantage plan? Well, of course, they want to save money. When the de Blasio administration came into office, contracts with every city union had expired. To find some of the money to pay for raises for the workers, the Municipal Labor Committee, representing the city's unions, agreed that one source of funds would be savings on healthcare costs. New York City is required by law to pay the entire cost of health insurance for city employees, city retirees, and their dependents. And as we all know, these costs have been going up dramatically. The city and the MLC agreed that they would come up with a way to save $600 million a year beginning in 2020. And they had 8 possible options for doing this. But the only one they seem to have really considered seriously was moving city retirees to a Medicare Advantage plan. Now, before I get into why this is such a terrible idea, let me provide a very brief history of Medicare. So Medicare started in 1965 as part of Lyndon Johnson's Great Society. It started with Medicare Part A, which is hospital insurance, and Medicare Part B, medical insurance. The cost of hospitalization in 1965 was the critical concern. So Part A covered almost everyone automatically, and there was no cost. People were going bankrupt because of hospital costs, not because of doctor's costs. So Part A covered everyone automatically. There was no cost, no premium for signing up. Part B covered doctor's visits and other outpatient services, which at the time were relatively cheap. I remember going to the doctor as a kid, and it was like $5 to go to the doctor. So Part B was optional, and it required paying a premium of $3 a month, and it paid only 80% of the costs of doctor's visits. But as I said, doctor's visits were not terribly expensive, so that seemed fine. Medicare Advantage, as we know it today, started in 2003 under George W. Bush, and it evolved from an earlier, less successful attempt to bring the HMO concept into Medicare. Medicare Advantage is private health insurance that's funded with public dollars. It is not Medicare. It is not public single-payer Medicare. Now, the cost for Medicare. Traditional Medicare used to be very cheap, but it's not anymore. There are monthly premiums. Part A has no premium, but the premium for Part B in 2022 is going to be $170.10 a month. People with higher incomes pay more. It's known as IRMA. It's an additional payment that you have to make every month. There are deductibles. The deductible for hospitalization is over $1,500 a year in 2022. And there are copays if you stay in the hospital longer than 60 days. Plus, you pay 20% of the Medicare allowed fee for seeing a doctor, a physical therapist, or other providers. Because there's no limit on what you might have to pay in coinsurance, and if you have serious medical problems, you can easily go bankrupt. Almost everyone on Medicare signs up for some sort of private insurance that's supplementary to Medicare. So up until the introduction of Medicare Advantage plans, most retirees chose to purchase a Medigap plan to fill in the gaps in Medicare. That is the deductibles and the copays. As you can see, the cost of paying the Part B premium to the feds, plus the premiums for the most popular type of Medicare plan, which is Plan F, adds up very quickly. Plan F is really popular because Plan F pays everything. It pays the deductibles, it pays the copays. So if you have the money and you can afford it, you pay in New York about $320 a month for a supplementary Plan F. And then you're covered, and you don't have to worry about going bankrupt for medical costs. But your total would be $490.10 a month this year under a typical AARP plan, or $5,881.21 per year. For people on fixed incomes who are retired, this could be quite a lot. At the bottom of the slide, you can see that Medicare in 1966 cost $3 a month, $36 a year. $3 in 1966 is worth $25.74 in 2022 with a standard CPI inflation calculator, or with a medical inflation calculator. It really, $3 medical care services in 1966 would cost you $71.81 per month today. Over $862 a year, which is nothing like what people are really paying now. So in 2003, Medicare Advantage was introduced. It provided a private alternative to Medicare. It replaces both Medicare and Medigap policies. And this slide shows some of the differences. Okay. Okay. When you have traditional Medicare, you go to almost any doctor in the United States and you show them your Medicare card. And then you show them your gap for Medigap, your card for Medigap insurance. The doctor sends the bill to Medicare. Medicare determines the allowed charge and pays 80% of it. Medicare then sends the bill for the remaining 20% of the charge to your private Medigap insurance. If you have the most popular Medigap plan, Plan F, as I mentioned, you never see a doctor's bill at all. If you choose a Medicare Advantage plan, when you go to the doctor, you show them your Medicare Advantage plan card, not your Medicare card. And the office says, oh, fine, we take that plan, or no, we don't take the plan. It's just like when you have private health insurance before you're retired. Some plans, some Medicare Advantage plans let you see out-of-network doctors, and some don't, just like with health insurance you had before you retired. But you can see that the monthly premiums for Medicare Advantage plans are much lower. The Medigap plans here I have are $88 to $320 a month. The $88 plan covers some, I think it covered none of the deductible, and it covers about 50% of the copays. But the Medicare Advantage plan, some of the plans are free. And the most expensive one I could find in New York was $84 a month. Not only that, the Medicare Advantage plans offer some benefits that traditional Medicare has never offered, like membership in health clubs, and also some modest dental, vision, and hearing benefits. Medicare does not offer any of these. So the lower premiums for Medicare Advantage plans and the added benefits explain why individuals are attracted to them and why they have been growing in popularity. And this chart from the Kaiser Family Foundation shows the growth in Medicare Advantage plans. So when they started in 2003, there were about 5 million people on them. As I said, they were an outgrowth of an earlier attempt of HMOs that never became that popular. But since 2003, you can see the growth. They're now in 2021, there are 26 million people on Medicare Advantage plans, and 42% of all Medicare recipients are now enrolled in these private insurance plans. Now, you don't get something for nothing. You're paying no premium, but you have to give something up. So all Medicare Advantage plans have limited networks of doctors and other providers that you are either required or encouraged to visit. If you go outside of the network, either you're not covered at all or you pay more. All Medicare Advantage plans require pre-authorizations for most diagnostic tests and for most medical procedures. And they often issue denials, which you can appeal, but many people fail to appeal. And so many doctors don't even ask for the pre-authorizations because they feel that they'll be turned down or it's too much trouble. So there are lots of tests and procedures that people aren't getting. New York City and the Municipal Labor Committee insist that their particular Medicare Advantage plan will work exactly like the current city Medicare supplemental plan, which is known as senior care. But that's simply not true. And that's why a judge issued an injunction delaying implementation from January 1st, which was when it was supposed to start, till April 1st. The city Medicare Advantage plan does have networks of doctors and hospitals, and it does require pre-authorizations for most tests and procedures. The network, the city says that you can go to any Medicare doctor under this Medicare Advantage Plus plan, and the doctor will take your card, your Medicare Advantage Plus card, and will see you, and you won't have to pay any more than you would have had to pay under the senior care. But doctors are not actually required to take you if they don't want to take your insurance. They can turn you down, or they can say, no, I don't want to deal with this insurance at all. So it's really very unclear exactly which doctors are in network, which are not. And that's why the judge said the implementation is terrible and we have to delay. And that's why New York City retirees don't want to move to this new plan. It provides coverage that is inferior to what they have had. The city is letting retirees keep their current senior care plan if they want to, but will have to pay the full cost of it, which is $191 a month. So, but you can see why New York City wants to move its retirees to a Medicare Advantage, wants to move us to a Medicare Advantage plan. Instead of paying $191 a month per person for 250,000 retirees, they're going to pay nothing per month, saving almost $600 million a year. Now, it turns out that New York City is not alone in wanting to save money on retiree health insurance costs by moving its retirees to a Medicare Advantage plan. Major employers, including state and local governments, school districts, and unions, have been making this move for several years. In 2021, there were 4.9 million Medicare enrollees in group Medicare Advantage plans. If and when New York City retirees joins this group, they alone will increase this total by 5%. The trend is clear and perhaps inexorable. More and more individuals and managers of group plans are trying to save money on medical expenses by moving to Medicare Advantage plans. So I've said why individuals make the move to Medicare Advantage plans and why group employers do as well. But there's another aspect to this. Medicare Advantage plans are enormously profitable for insurance companies. There are three separate markets for health insurance. And I'm talking about all health insurance, not just retiree health insurance. There's the individual health insurance market, which is now primarily Obamacare. And it's shown in this chart in green. That's the individual market. If you don't get insurance through your employer, you're in the individual market. There's group health insurance. That's insurance provided by your employer, which is yellow on this chart. And then there's the Medicare Advantage market, which is shown in blue. The average amount by which income from premiums exceeds claims costs, that is, the amount by which income exceeds what the companies actually spend on healthcare per individual, is almost double in the Medicare Advantage market. So the income exceeds what they pay out by $1,608 in the Medicare Advantage market. In the individual market, it's only $779. In the group market, which is less regulated than the individual market, it's $855. So these margins are not exactly the same as profit because there are also administrative costs, which are not accounted for here. But you can see that private insurance companies make almost twice as much money on Medicare Advantage plans as on other health insurance they offer. Medicare Advantage plans are also the company's biggest growth market. And that's why insurance companies so aggressively advertise their Medicare Advantage plans every year in the fall, when it's time for retirees can consider switching. And they so aggressively court those employers who are still paying for retirees' health insurance. So why are Medicare Advantage plans so profitable? For some of the reasons I mentioned earlier. They pay less for services because they have a limited network of doctors and hospitals. They apply pressure to reduce the number of services by requiring pre-authorizations. They upcode, that is, they claim to the federal government that their enrollees are sicker than they really are to collect more money per enrollee. Medicare Advantage plans are paid per per head, per person that they enroll. And they also collect a small premium from the federal government, which increases if their star ratings, and I won't go into that, but that's supposed to be satisfaction and whether they're doing a good job. So if their star ratings are high, they get more money. In 2021, the 42% of Medicare recipients enrolled in Medicare Advantage plans accounted for 46% of total Medicare spending. So we're actually spending more money on Medicare Advantage plans. And this is public money. We're talking about the premiums, but the premiums that individuals pay. But most of the cost of Medicare is funded by the payroll taxes that we all are paying now or paid when we were working. So I hope by now you can see why the attempt by New York City to move its retirees from traditional Medicare is not just a local matter. New York City's move is probably the largest forcible move yet of retirees from traditional public Medicare to a private Medicare Advantage plan. And as far as I know, this has been the only move that has been met with widespread, sustained resistance. New York City is doing this to save money, and perhaps city taxpayers will save in the short run. But if traditional Medicare disappears, we'll all be paying in the long run. So Medicare Advantage is private insurance paid for with public funds. That's our 2.9% tax on wages that employers and employees jointly pay. And this money is now going towards insurance companies' profit, not only towards healthcare costs. So it's not the providers who are getting the money, it's the health insurance companies with their profits and their very large payments for their senior executives. So if I can answer any questions, please let me know.
Well, thank you. Thank you so much, Bonnie. That was a very comprehensive explanation about Medicare and this Medicare Advantage plan. So in your opinion, which one is better? Which one do you vote for?
I want to keep what I've got. I want to keep traditional Medicare, which is a single payer plan, which is publicly funded, and where the money that the public pays goes to paying the doctors and the hospitals and not goes to insurance company profits, and where I can choose what doctors I want to see, and where doctors are not going to be stymied and required to get pre-authorizations in order to send me for an MRI or have my cataracts done or whatever. I don't, this idea of being under the thumb of the insurance company and having them determine what's going to happen to me and which doctors I can see and what procedures I can have. It scares me. And so I'm going to, come up with the money and pay for my own pay for senior care, what the city is asking.
Yeah. Any questions from members?
I see that Ronnie has their hand raised.
Ronnie?
Hi, thank you so much. So are you saying that, are these your actual issues? Are you not able to find the proper clinicians and you're denied choices and procedures?
Well, this program has not started yet. It's starting.
Yes, but
April 1st.
I understand that, but you are saying that that's how it is going to affect you.
The city says that there won't be these kinds of problems, but we know that these kinds of problems exist with other Medicare Advantage plans. And we don't, since that's the only way the insurance companies are going to make money on it, is by trying to reduce the number of procedures that people have, the number of tests that they get. I don't see any way that this plan would be any different. So I find.
So you're saying that you will, so you are not going to have, so you are going to have interruptions in your service and your care?
I am not, because I am not going to choose this plan.
Okay, so how is that? And then on the aggregate, so if it doesn't affect you in that way, And there's going to be a certain coterie of retired and about to retire municipal workers that this really affects more immediately or acutely.
People are in a
What-
panic about this. I'm hearing from them, my colleagues, all the time. Some people are afraid that they don't have the money to pay the premiums to stay on senior care, so they want to go with Medicare Advantage. A lot of people are getting cancer treatments at Memorial Sloan Kettering. There was quite a long delay before we found out whether or not Sloan Kettering was actually going to be in the plan as a hospital. And and not all of their doctors will agree to be in the plan. So a lot of people have been getting treatment from particular doctors, cancer treatment that, is life-saving for them. They're not sure if they're going to be able to see the same doctors and have the same treatment. They're not sure whether the insurance company is going to second guess what treatment they get. So they're afraid.
Well, that really, I mean, again, it's so, there's a lot of detail and minutia. And there, it's so particular. Again, so just from what you're saying, if a person is going to Sloan Memorial and they're getting a cancer treatment, and when there would be a possibility of this affecting that person, are you saying that they are not going to receive the same amount of care if they have to go to a different provider?
It's possible. People don't
But-
like
but
being
not- but
forced to
not-
change
but-
their doctors. We don't know. I mean, there is experience with other Medicare Advantage plans elsewhere in New York and elsewhere in the country, not this particular plan. But yes, it does happen that people on Medicare Advantage, they start when they're very healthy, and then all of a sudden they get sick and they discover that the treatment they need, the doctor they need, is not in the network. And it's difficult for them to find somebody who is in the network who can give them the treatment that they need. And if they can, they switch back to traditional Medicare so that they can get what they need, because there's no guarantees that your doctor will be in network, that the doctor you need will be in network. So yeah, there's a great fear that you won't be able to get what you need. Some people do
okay.
fine.
All right, okay. And then what are the other systems that are horrific around the country, and which one is more apples to apples to what would be implemented in New York?
Well, what will be implemented in New York, they're saying, is a special Medicare Advantage plan that they say is going to be wonderful and perfect, and there'll be no problems for anybody. But as I mentioned, there was a lawsuit brought against the implementation, and the implementation was delayed by a judge because people could not find out if their doctor was going to be in the new plan. We're talking about 250,000 people. They're calling a helpline and they're saying, my doctor is so-and-so. And the insurance company is saying, oh yeah, they're in the plan. And then they go and talk to their doctor, and the doctor says, I don't think I'm in the plan. I never heard of this plan. It's been a big disaster. And then there are people who are retired from New York, and if they want to move elsewhere, they don't know if their doctors will be in it or if the major hospitals outside of New York will take it. They still don't have a contract with one of the hospitals in New York. So they keep, basically the city has been lying to people, because they say that every doctor is required to take it, and it's simply not true. So there is no other plan I can compare it to. I told you about typical Medicare Advantage plans, that they have limited networks and they require pre-authorizations, and they do sometimes deny pre-authorizations. One other example I can give is that when people need to go, if they've been in the hospital and then they go to a rehabilitation facility, traditional Medicare will pay for the first full pay for the first 21 days, I think. And after that, you need, they will generally pay 80% after that, and then your Medigap plan pays whatever it is, what the difference is. People on Medicare Advantage often find out that after that 21 days, their medical insurance company denies authorization to continue. And so they either have to pay for rehabilitation themselves or they're thrown out of the rehab facility. So these are the kind of horror stories that we have heard over and over about Medicare Advantage plans.
All right, so
Right. And also
I'm
when it
gonna
comes
move now.
to,
I'm gonna move
excuse
now.
me, LV, this is so important. And my next question is very germane. Please, let me get this all out because this is a huge issue. Thank you, with all of the retirees, how many retirees would you say that affects? If they had an emergency, they go into long-term care, and then they have this medical emergency. These are all people who are over a certain age, a retirement age.
We're
What
talking about
happened
people
to,
over 65, yes.
yes, so why are they not prepared with their planning, with their life planning? One thing about a municipal worker is, unlike a person who may be employed during their key employment years, the municipal worker has the advantage of a pension and this comprehensive coverage, where an individual in a private care, they would have had that luxury in the 1950s, but it went away as soon as individuals had to have their self-directed IRAs and so on and so forth. And in addition to that, there are benefit packages that help to mitigate this. And with that, there's a ton of information about buying insurance to specifically cover these type of scenarios and conditions when you're retired, to give you that extra cushion. And you're saying that there's, maybe $200 a month on average that they would have to pay. That is still a tremendous bargain compared to if they came out of retirement and had to try to find a policy to cover their emergency needs. They wouldn't qualify. They would be most likely unhealthy from preconditioned conditions or just overweight. And the premiums would be astronomical, or they would be denied outright, which would be more destitute than paying a $160 premium a month. A lot of people, like a Cadillac plan is something that most people will never have. And this at least is something. And in addition to that, you were mentioning the other systems, the municipal systems around the country. One thing about, I'll mention them in particular, Chicago and LA, they are not as large as New York, but they're very big. Luckily, New York has been very astute fiduciaries when it comes to a lot of the policies and procedures. And that has kept our system solvent for many decades. Going forward, that has to be shored up. And I would say it's hard to fault them, the state for wanting to keep that solvency strong.
Okay, a couple of things. One, the insurance you're talking about is Medicare. That's what we have all paid in for.
Actually, I'm actually speaking. I should delineate. I would say if you're an adult, you work for the city, you probably most likely raised a family and had a mortgage. Why wouldn't you have had a proper additional supplemental insurance that was purchased 30 years ago, which would cover, and you wouldn't have to think about it now if you're in retirement? And why isn't that something that is fostered?
Can I say a couple of things?
Yes.
First, municipal workers. As I said, New York City is required to pay for their health insurance. And as the cost of the health insurance has been going up, they've been giving up raises. So that actually the total benefits package that we get, for years, city employees have given up a lot of money in raises so that they could keep their health insurance. If we were working elsewhere, we'd be making more money. But this was the deal, that the city paid for our health insurance now, and they paid for our health insurance when we retire. The average city worker, the pension that the average city worker gets, I was trying to look this up recently, but it's something like $30,000 a year. I think it's something like $24,000 a year. Most city workers don't make very much. We're talking about the clerks. We're talking about the school crossing guards. Okay. Most of them don't make a lot of money. And so that we're going to wind up with a two-tier system of health insurance for retirees. Those who can afford it will pay the $200 a month and get what the Medicare that they thought they were always going to have, which is the Medicare that I think most of us thought we were going to have. I think most of us thought that when we retired, we were going to be on Medicare. I mean, they're talking about Medicare for all, that we thought that was single payer and all of our health costs were going to be covered. But it turns out it's not so. And it turns out it's getting a lot worse, not just for municipal retirees, but for everybody, because everybody's being pushed into these Medicare Advantage plans, which is private insurance. And that's what we thought we were getting away from when we retired. So,
all right. Thank you, Bonnie. Thank you so much.
All right. So I want to give chance for the other members to ask question also. And so just please make your questions succinct. So Brandon, who's the next hand?
I see Sandra has her hand raised.
Sandra?
I think, okay. Partly I forgot my question in all of this. So I'm sorry. I just really have to say you have to be a municipal worker to. It's unfortunate that it's so hard to seem to understand this issue. It's shocking to us. It's shocking to all of my colleagues who it's a contract. It's called a contract, and we expected the city to uphold its end of that contract. And I think what Bonnie said, a number of things. We were lied to up and down. Unbelievable how much we were lied to. I couldn't believe it. None of my doctors are covered, right? I've looked up every doctor. Now at least we can look them up. Not one will accept the Medicare Advantage, right? So we were just bold-faced lied to, and lied to at many meetings. It was so distressing. But also it's a contract. And they did behind closed doors, they dropped our contract. And as Bonnie pointed out, we never got great wages. We love the work we did. And we made an assumption, not 30 years ago that I decide that somebody was going to break the assumption. I understood what the deal was. And then that was done behind our backs. That's disgraceful. and that's city government. I also just want to tell you, I brought it up here because one of the things I found is that I couldn't get anybody in city government to respond to my emails. I was like a crazy person writing emails to everybody. Nobody responded to the emails. This seems to me, this is, if you want to talk hyperlocal, this is what we're living. And not one person in government, no, Liz Kruger's office responded. Nobody else did. And I wrote every city council person that I could think of who was involved in the committees and so on. That's a disgrace. You know, so we're suffering for this. And I think Bonnie's point is that people who are making low wages, you're just going to see the tail of two city pulled right out of this system, right? That and de Blasio is the big, oh, we can't have that. But he just created it in medical care for retirees. And we have every right to be treated with the respect that we had when we worked. That's what we assume. And so it's a very upsetting issue for all of us. So I'm sorry, that's where I'm sorry, I forgot. The question was, we do have, I'll get back to the question, but it's very heartfelt. It's a very heartfelt issue. And I so respect what Bonnie has done to put it out there so we can hear it. This is lowest level of government. Maybe we can have a voice and say, what happened is not the way government is supposed to work. You don't betray your workers. You know, and I certainly hope we can get to that point, just so, you know, certainly where I'm coming from. And I think Bonnie's presentation was so clear about, you know, what's going to happen and what, you know, basically the betrayal that's been involved. So the question is, what do you think is going to happen with the, so there is a group that has gotten together to fight this legally. It is in the courts now. And at this point, it's that they have to clean up their act and actually be honest about what is going to need pre-certification, who is in the system, which doctors. But the second part is, can this be addressed as simply as a violation of a contract? And I'm wondering if you have any thoughts about where this is headed. One, and actually the second one is, do you have thoughts about what we as a committee on the community board might be able, how might we have a voice? Can we have a voice in this issue? Is there a place for us in this? And I mean, of course, up the committee, but.
Well, as far as whether it's a violation of the contract, I think the judge has not really ruled on that. He seems to have indicate that we probably don't have a leg to stand on. Possibly it's a violation of the contract for current retirees, but then they could implement it for future retirees. So the argument that the people who brought the suit are making is that we were promised at the time we retire that our benefits would not be changed, that this is what they would be, and that the city made this change, so it's a violation of a contract. I don't know if that'll go over or not. If the judge rules that that's the case, it all collapses. There's no money in it for the insurance companies, just for the 10,000 people who are retiring each year. They really want this $250,000 group of people to be in their insurance plan. As far as what the community board can do, this is a city. It's a city decision. It's a mayoral decision. Adams hasn't said which way he's going to go. There are other ways to save money on health insurance costs. New York City is almost alone among big employers in not self-insuring. And self-insuring would probably save more money than this move to Medicare Advantage does. And I don't know why the city does not self-insure. That means the city is paying per person for insurance plans for everybody, for the actives, as well as retirees. They're paying as if they were buying a plan on an individual market. And so they're paying as if the insurance company is assuming the risk, but they're so big that they can assume the risk themselves. And so they don't have to pay the extra premium for having an insurance company assume the risk. And it's been estimated that they would save way more than they're saving now by moving us, but they haven't even considered this. So that's another betrayal. So I think that the community board can say that, the city should look at how it pays for health insurance. Maybe they're paying way too much and can save more money instead of just, betraying the retirees like this. Let them take an honest look at what they're paying and how they would save. And they would probably save a lot of money if we moved to single payer healthcare in New York State with the New York Health Act. It would save us all a lot of money. But that's a different topic.
Can I just say, when you say does that mean like they pay GHI to cover, is that what you mean? Like that's who they're paying and they could instead be the insurers themselves?
Right, they would pay
Got it.
GHI to administer the costs. But when a small when a small company pays for insurance for its workers, they are paying a premium because in case one of their workers comes down with some catastrophic cost. In a small insurer, they can't afford to run that risk, but very large insurers don't pay the extra premium for the risk. Very large employers don't pay the extra premium to cover that risk. They just pay whatever it costs, basically. So if it costs a lot of money one year, maybe it costs less the next year. They pay the cost of the medical care and they pay for administering it, but they don't pay the extra cost to assume the risk, for the insurance company to assume the risk.
And now that is what we're doing?
New York City is paying as if they were a small employer.
Got it. Okay. Thank you.
Okay.
All right. Marty? Marty?
If it's in the courts, there's really nothing we can do as far as this. Having been responsible over many years, changing insurance carriers, fiddling around with the plans that I offer the individuals who work in my organization. I understand the city trying to find the lowest cost for services for a segment of the population that they are covering. Most non-governmental organizations have no health insurance for their retirees. This is primarily a governmental issue. I know New York State does self-insurance, with United Healthcare being the administrator of that plan. It was my assumption that the city was doing it the same way. I guess not. But you guys are the low fruit. Their next move going forward would be adding additional plans in network and out of network for existing employees, if that's not yet involved, because that's going to happen. The cost of having PPOs, that's like Medicare, where you can pick your own provider, is fading. The costs are extraordinary. And when I offered the in-network only plan to my folks, I gave them an incentive of giving them a few $1,000s as a bonus, so as to go into that network, and I saved 20% on the year, and in health insurance, 20%. We're talking about a couple $100,000. The city is going to be doing this more and more. Again, people who are already retired is low-hanging fruit in so far as that. Trying to do it to active employees, then the unions are all up in arms, and so they have other problems. But maybe your union, the unions that you were affiliated with would have, well, I'm sure they have something to say about it, and they may be just accepting it.
No, the union sold us out, actually. It
Yeah,
was the
well,
u-
there you
It was
go.
the unions who got together with the city to come up with this plan to save money so it can pay raises for the active employees.
There's the answer.
Okay, Brendan.
I'm sorry.
Brendan, any other hand?
I see Ronnie's
You know,
hand is
just like
raised.
thank you, Brendan, sorry. Just like what Marty was saying, and back to Bonnie's point, it goes back to if you're a smaller public employer, you know, and you have a plan with a provider, those are all pulled together. And, you know, and then that also brings in the reinsurers. So, you know, I can like, and as Marty said, I can see exactly why they would try to offer this. But, you know, just keep in mind that the New York workers are going to be pulled together and you know, that has a lot to do with that as well as with the reinsurers.
I think I just wanted to make one final point. If you are all looking forward to having Medicare when you retire, I think and if you're far from retirement, the way things are going, it's not going to be there. Not the way you thought it was going to be. I think people thought that Medicare, when they retired, they would have Medicare. They can go to any doctor who took Medicare and they would not be bankrupt with medical costs and they would have really good medical care. And that's why, you know, the call for Medicare for all has been going on. But Medicare is disappearing. If 42% of retirees are now on Medicare Advantage plans, and the way they're advertising and the way things are going, before very long, it's going to be well over 50%. And at that point, I think there's not going to be any hope of saving traditional Medicare. So, and we're all just going to be in, you know, private insurance plans for the rest of our lives and at the mercy of the insurance companies.
Very good point. Any hands, Brendan, any more questions, or Sandra?
I just wanted to ask Marty, why you said that since it's in the courts, there's nothing we could do about it. And I didn't understand your comment. So could you explain that?
Sure. If the issue is in the courts, there's nothing the community board can do about it. We can't have issue a resolution to the court. We just have no standing there. They're handling it already.
Actually,
Eventually, if they, yeah.
It's up to Adams right now. The court has said it can go ahead April 1st. And so it's up to the mayor, whether he wants to let it go ahead or whether he wants to change it.
So could there be a resolution of support for the continuation of Medicare that goes to Adams? Right?
Sure.
So we could do that, right?
Mhm.
Okay. Okay. So it's not a dead deal for us. We still would have to decide if we want to move ahead on something.
Yeah.
Okay.
So should we write a resolution?
It's up to the committee. It would be certainly, I think, a resolution of support that, and hopefully it would spur other, you know, city council folks and so on. The more voices you get in this, the better, I think, at least the support that take a look at this and realize what its impact is. So that's what I would hope for, I think. But it's a committee decision.
Do you want to draft a resolution, Sandra?
I have never drafted. I'm a new member of the board. I have two things. I never drafted a resolution, so I have not a clue how to do it.
Okay. Okay.
So, I mean, I'd be happy to work with somebody, but somebody has to teach me how to do that. And then I don't know what you do with it once you write it. That's another, it's like, it's a two-part. You write it and then what do you do? And then how do you write it? Because I know there are all these whereas, et cetera. I know the whereas, but I have not a clue how to develop it. So I would have to work with somebody on it.
Yeah.
Hi, Sandra. I'll work on it with you.
Ronnie, you seem so opposed to it that it makes me uncomfortable, actually. I mean, your sense was that.
Well,
it's a
you know what?
proposition.
That's because I'm an insurance executive.
Okay,
And I
I'm
know
not
the
sure
ins and
that
outs of
that's
all
the
of
best
that.
combo then, quite
Well,
honestly.
well, well,
And
I
that
mean,
came
I
across, yeah.
no,
Um,
because there's a lot of things that it's a serious issue that I take very seriously because um, I see too many scenarios of people who through just they're living their life, they're doing the best they can, and then circumstances happen. They end up in a situation, and yeah, they don't know. You are thinking of a certain outcome. You're going to go to the hospital. You're going to get taken care of. And most people aren't thinking about that. The hospital administrators, the clock is ticking. And then it gets to 21 days and you are they're looking at close next of kin, they're looking at everything else, and
Okay,
then
well,
it's
wait, I'm going to interrupt because all I need, I want to work on a proposal or a resolution in support of the unions and individuals who want to, the right to continue on the Medicare, Medicare and senior care. So I don't know if that's what
yes.
you're interested in doing,
Oh,
but
of course it is.
that's what I want to work on.
And
All right,
that,
so Ronnie Ronnie
excuse
can
me. Yeah,
help, can
I-
guide you, Sandra.
What?
Ronnie
I-
can guide you.
I'm sorry. I'm sorry. I couldn't hear. Sorry. But yes, that is correct. I understand that. But I'm just saying that I see. I care because I've seen how it affects people, and I know that there are the horror stories of people lined up in gurneys, in long-term care hallways and being turned out on the street in their gowns with no place to go but a trash bag of their immediate belongings, families losing everything, savings, houses gone, cars gone, because that's what happens. And without proper planning, too many people are left to that type of peril. And having a choice for you is always a good option to have. But and also on top of that, you also, you have to be, like Bonnie was saying, Bonnie, I'm not the youngest person, obviously, but from years ago, I knew that there was no way that I would be able to think about retirement in a more traditional sense. And I've been like very proactive and know that there are things that you can do to fortify yourself like that. But and if I am in favor of this type of plan, because it will benefit people. But I am saying I just see the entire gamut, and there are options out there, and I would just hope that people would be able to see that and put that into their planning, into their minds, as they go into retirement. There's a lot that people just don't think about at all. And that's unfortunate, but you have to have that information out there.
Yeah, good. All right, so Ronnie, so you're gonna help Sandra, right?
Of course.
Okay, good.
Well, I'll just send you the thing and then somebody's going to teach me how you do I need to learn, how you
Right.
actually do resolution.
Yeah,
The
Ronnie,
other one,
Yeah.
wait, the other one is, shouldn't the entire committee decide that they want to do this? I don't want to decide for the committee. People say, hey, we take a vote and we don't want to do this. That's a democracy, right? So I think-
Exactly,
Right.
exactly.
We are deciding to write to support this. That's why I just wanted to know who can do the draft. Because somebody has to do the draft. Because,
Right, but we don't decide first. Again, I don't know the procedure. Don't we decide first that you even want to do a draft? I mean, if the committee says, I don't want, this doesn't make any sense, then, right? Wouldn't we do it at the outset?
So just to interject here, there are a couple of paths the committee could take if it is interested in a resolution of support here. One path is to say, oh, we support a resolution on like whatever position the community board takes on this. This person or these people will draft the resolution of support. Another route that, the other route that some committees take sometimes is, let's draft a resolution and we will look at the draft resolution at the next committee meeting.
yeah.
Now, I will say that the second option is used more with matters that aren't necessarily time sensitive, which this sounds like a little bit more of a time sensitive matter. So I don't know if the second option is one that the committee wants to pursue, but that's ultimately the committee's decision.
Yeah. Andrew, you want to say something?
Oh, I was just going to say, in response to Sandra's question on support from the committee, I would be in support of a resolution and happy to help with drafting. I've only done one other resolution in the past, but happy to help support.
Thank you.
Andrew.
What do we do? Exchange emails? How do you do this? Aside from how do you write it? But
I think that would be great, because I would say,
wait, too many people.
I'm sorry, this is Ronnie. I was just saying that, Angie, we can work on it together with, with Sandra, and because it's complicated. It's going to take 3 people to write it, and this way we can all write it together. So I have a little bit more experience writing resos, and it will be good practice for you two as well.
Wait,
Yeah.
so
I'll send you my email.
But Sandra, it's just writing a draft, okay? It's
Okay,
going to be presented to this committee, and we all can make comments on that draft, okay?
Okay.
Right.
Be so anxious.
Yes.
Andrew is there, Ronnie is there, I'm there. I'm going to edit also the draft. Okay.
So we're all going to be on an email. So we will have. So what?
Andrew will take the lead. Andrew will take the lead in communicating with you and Ronnie. Okay. All right. So let's move on. Any other question from the committee members?
LV, just to interject here, just to sort of put Sandra's mind at ease a little bit, there is a resolutions template on our website on the resources for CB6 members page. I will make sure to send that resolution template to everyone who will be working on this resolution, Sandra, Anju, and Ronnie. That way, Sandra, you can know generally what sort of formatting our resolutions take. And that way you all can start drafting that resolution. I can also share our resolution tracker and database, which has past resolutions. That way, Sandra, you can see the flow of our resolutions, generally speaking.
Yeah.
Thank you. Okay, good.
Thank you, Brenda. All right, so moving on.
I'd like to thank you for having me here, and I guess I will leave now. So thanks very much.
Thank you so much, Bonnie. Thank you so much.
Thank you, Bonnie.
All right, so for my report, I just wanted to make an announcement. And anything else? Okay, I just want to make an announcement about our third series on health living in the community, which is on January 26th from 1 p.m. to 2 p.m. And again, the topic is staying active as you get older. We have a speaker from the American College of Sports Medicine who is a certified physiologist at NYU Langone's Sport Performance Center. And please, I urge you to support this activity. Please share with your family, friends, or any other contacts of yours that can benefit from this session. It is of great benefits to learn some easy activities that we can learn to do at home, especially we are mostly home because of the COVID crisis. Okay, please. And any other new business?
I just wanted to share that I participated in a discussion that was sponsored by the Federal Reserve Bank of New York, talking about the investing in health at the intersection of business, public health, and community development. And it was really insightful and informative. And as soon as I get the presentation from the director, I will forward it to the members, to you, LV. Thank you.
So, Ronnie, do you think we should put that in our agenda for February? We can invite a speaker.
No. But I can invite a speaker. I know that there is they are going to have some other topics that are going to be coming up, and they have a colleague in this team that specializes in healthcare, and so I will find out what he has coming up for that. But what they do is their work is really incredible. So I'll make sure to give you those topics, and then you'll feel free to see which one you would like. Thank you.
Okay, that's great. Thank you. Thank you so much. Okay, any other new business? If there is no more objection, I will join the meeting.
Bye, everyone. Have a great evening. Stay warm.
All right. Thank you so much, everyone.